Welcome back to the Neurologic Wellness Podcast. I'm Dr. David Traster, and I'm very excited today because I've got Dr. Paul Brewer here. And me and Paul know each other a little bit. We met each other a few times. And there's two things I know about Dr. Brewer. Number one, he's probably one of the nicer people I've ever met. And number two, he's one of the smarter people I've ever met, right? And so that's a good combination for me. And so let's get right to it. For people who don't know who you are, why don't you give a little introduction about your background, your history, what you do, what you specialize in, just so people could have a basic idea before we get started.
Perfect. Yeah. So I'm Paul Brewer. As you can tell by my background, I'm originally from Hawaii. That's where I grew up, and I was a surfer guy. Was in the ocean a lot, so I have a really big love for the mountains and the ocean. Background: I'm an optometrist by trade, and currently live in Boise, Idaho. My wife's from Idaho, so we moved up here to be by her family. And originally, I started off with like being a vision therapy doctor. So a lot of people know about vision therapy, and I did a lot of sports vision. So I worked with a lot of athletes, and like I was really like interested in concussions because given my background, I played a few sports in high school and I did water polo in college and stuff like that. You think in water polo you would never get concussions. Well, and here's a funny backstory. So like I'm actually a better football player. I'm like, if you look at my size, people think I'm a football player, right? So like, and my nephew's actually playing at Vanderbilt right now, and they're doing really well, which is awesome. But like my mom never wanted me to play football, and she's like, oh. And then when the water polo coach, got all the surfers on the North Shore to play water polo, and I gravitated towards that. My mom's like, oh yeah, you'd be fine. I got like probably like 10 concussions playing water polo because you get elbowed in the head, punched, and everything like that. And like so I kind of gravitated towards concussions. I was like, because I had all these issues. I had a convergence insufficiency, which is like kind of an ability to turn your eyes in. And given my background, I didn't know that was related to concussions, but it probably was predisposed to that anyways. But having these multiple concussions made it harder for me to read, harder to comprehend. So I did a lot of study groups, and I did really well in high school, college, and optometry school. But when I went to optometry school, they're like, "Oh yeah, you have all this stuff," and I did some vision therapy, and I got better, and I was able to read better. But there was still this little disconnect, if that makes sense. So this is kind of the backstory.
Mhm.
So now fast forward, like I did the vision therapy program, I got a lot better, but there was still something off. And I started practicing vision therapy, and as I started learning more, I bumped into actually Matt and at a conference, and we started talking more, and then I started learning more about the Carrick Institute and other types of neurological institutes. And I'm kind of like a sponge. I like to learn everything. So I started learning more about the brain, and I was thinking, man, we're treating like vision almost like as a disconnect from the brain, but everything we're doing in vision therapy is still a brain exercise, but it's about understanding those pathways in the brain to whether to be able to understand whether that is going to help vision or not. Then I started understanding stuff too. I like looked at some of your courses, and I'm like, oh wow, look at this whole visual vestibular integration thing going on. And I started talking to Jeremy, and we started talking a lot more and kind of talking about different patients. And I'm like, oh my gosh, there's this huge connection between vision and the cervical and proprioception and the vestibular, and one thing can affect the other. And kind of this is kind of a funny story because I was in the gym at one point doing vision therapy. I had a sports vision practice, and as I translated people and started moving people doing these different movement exercises, I was like, wait, why did their vertical go away? Like, I'm thinking like, why is there a vertical deviation? So vertical deviation, like for the listeners, like a vertical deviation is one eye's like that, one eye's down, or like that. And because I'll test and retest, between sessions and whatnot. And I'm like, how did their vertical get better? But I started looking at translational stuff, and I started looking at again some of your stuff, and I'm like, wow, there's a huge correlation between that. And as we started implementing exercises or brain exercises through the tests we've done through like VNG testing and so forth, prostography, we were able to see like, well, if we did this exercise with this visual feedback, it'll help their vertical deviation get better, or their exophoria or esophoria or so forth get better. That's kind of how I delved into the whole realm of neurology.
Amazing. And then why don't you give us a little introduction when you look at a patient and vision by itself? Tell us a
Hmm.
little about the vision in the brain, why it's important for people. You could relate your own story because a lot of people might have a convergence insufficiency
Yeah.
and they feel it, but they don't understand why it's there. They don't understand what's
Hmm.
going on. And so it's almost like a weird perceptual problem that they
Yeah.
can't put something objective to. So why don't you give a little
Yeah.
explanation about vision in the brain and how it relates
Yeah,
to
for
your
sure.
typical
So
patient?
yeah, for sure. So like, the whole convergence insufficiency, like we throw that term around like it's this cool scientific term, right? And then when people hear it, they're like, what does that actually mean? Because they can't correlate it to what they're feeling. And convergence basically is the inability to turn your eyes in or keep your eyes in when you're doing your tasks. And a lot of times people like will have symptoms of like brain fog. It can be anything from brain fog to eye strain, double vision. It can be tired eyes, eye strain. So there's so many different symptoms it could actually have. And that's why it's hard because someone would say, I have brain fog, and it could be a concussion issue, it could be a convergence issue, it could be so many different things, right? So when people have these symptoms, they don't know where to go, or they go to their primary care and they're like, oh, I have an attention issue. And what is the first thing that a lot of people do when they have attention issues? Medicate. So we're really quick to medicate people based off their symptoms, but in reality, there could be this underlying brain issue that's causing it. So the same thing with convergence insufficiency. I went my whole life, I had contacts my whole life. I wore contact lenses, and nothing that my doctor was doing wrong. I mean, they're doing a great job. They gave me, great vision, but they didn't, the doctors I saw at least didn't understand the relationship between the convergent system and the brain. So although I was seeing clearly, and that's the first thing we obviously test as optometrists, right? We would say, okay, does a person have 20/20 vision? And all 20/20 means is people think 20/20 has perfect vision, but really all it means is you're seeing the chart from 20 feet away and the bottom number is the size of the letter. So someone can have 20/10 vision and have better than perfect vision. But that doesn't mean that they have perfect vision. So clarity vision is this one component of the whole visual pathway. So although I had clear vision, I had this brain fog, this kind of eye strain. When I read, I just like, oh my gosh, I can't understand anything. And the way I got around it, I had a really good group of friends growing up. Like we had 8 of us good guys, and we always studied together. And I found that when I studied with them, I just listened. I did really well on tests. When I didn't study with them, I did poorly in tests. So I just always studied in groups. And that was my workaround without even knowing that that's the reason why it helped me. So sometimes people are able to compensate really well. Like, so they could have this, concussion. So why does one person have a concussion, the other one have the same symptoms, but one can compensate really well? And that deals with a whole nother realm of stuff we don't have time to talk about. But people are good compensators and they can go for a very long time having these issues. And what I like to tell patients is like, hey, are you going to go on that hike? So we're going on a 20-mile, backpacking trip. Would you purposely pick a bag that's 20 pounds heavier? Like there's a 20-pound weight in there. And no one in the right mind would do that. Maybe my wife would because she's like really intense like that. But, like most people would say, no, I wouldn't pick that 20-pound heavier bag with a 20-pound weight in it. And that's kind of what we're doing when we're compensating. We're carrying this bag with this 20-pound weight when we shouldn't have to. So that's the whole thing with the convergence. So when we're doing an eye exam, we're looking at the clarity of vision. And that's the first thing that doctors do. And a lot of times they neglect the other parts of the visual pathway. So as an optometrist, like vision, strictly vision testing, I always look at clarity of vision 20/20. Then we see if the vision's stable. So you can do like, dynamic vision and so forth. So is that clarity vision stable? Then from there, I look at contrast sensitivity, seeing if like at different light levels or if the chart's at different darknesses, if they can still see the letter. Then I look at accommodation. So accommodation is the ability for the eyes to focus far and near. So there's this little like magnifying lens in your eye. And when you're looking far, that magnifying lens is just relaxed, like just like that. But when you look close up, there's an automatic system. Should we talk about that or just go?
Yeah, talk about it.
Okay. Okay. So there's this magnifying lens in your eye, and there's these muscles in your eye. They're called ciliary muscles, and they automatically contract. So the parasympathetic system feeds into that, and it automatically contracts when you have this stimulus at near that may be blurry. So it's an automatic response. You don't say go gadget, focus my eyes up close, right? I mean, we just look up close and it automatically focuses. It should do that. So the lens goes like this, gets bigger, and it creates a bigger magnification power. So like when you use a magnifying lens to look at something up close, it's the same principle that the eye does. So when the lens gets thicker, it has more magnification power, which makes things magnified up close. Then you look far, muscles relax, and then the lens goes back. So what happens in people that have concussions and so forth, they might have a inability to react with those muscles. So the lens is working fine, but the muscles aren't firing properly. So now they have like an accommodative spasm or infacility or insufficiency where they're unable or have a reduced ability to focus up close. And so what happens, they'll come in saying, ah, sometimes it's blurry. Or a lot of kids, when they look up close and look far away at the board, it takes like 5 seconds for the board to be clear. And then that'll cause like eye strain and headaches and so forth. So that's another thing we look at as a combination. Now, a lot of people say, well, I'm older, like when you're 40 plus ish, when you age, this lens becomes less flexible. So it gets more epithelial tissues, which means it's getting thicker, so less flexibility. And what happens there when you hit about 40 plus, those muscles are working fine, but the lens can't flex anymore. So now you can't do that magnification anymore. And that's why you need readers.
Let me ask you this.
But yeah, yeah.
Someone with a background in optometry and vision therapy, I see a lot, I'm sure you see a lot, where people have vision problems. They say, I went to my eye doctor, I got 20/20 vision, everything's normal, it's not my eyes. So why
Yeah.
don't you talk a little bit about the eye movement component with vision
Hmm.
relative to just the visual component by itself? So you talk
Yeah.
about
Oh, like I
convergence
move like
factors,
aquamotor.
its efficiency. Why don't you break it down into different eye movements and what do you see in your practice that you have to focus on? Because how often do you see people have vision issues and their vision's 20/20, but they've got other
Hmm.
reasons with their eye
Yeah.
movement that's not working as
Yeah.
well.
Yeah. So we kind of already talked about the eye focusing and the glasses and that part, which we're putting on the side.
Mhm.
Now we're like, okay, well, they have a convergence insufficiency, right? So they come in, they get glasses or contacts and they're seeing clear, but they're still having these, brain fog and eye strain and so forth. Like, so convergence insufficiency, when you're turning your eyes in like this,
Mhm.
I mean, basically there's these two muscles called the medial rectus and it pulls the eyes in like that. Or it could be the superior oblique too, right? So it depends if you're going like that or like that. But typically when you're reading, you're going in and down. So you're kind of using really both muscles. You're doing the medial rectus and the superior oblique. But that's a side note. But basically, when you're having an inability to do that, there's a couple options it can be. And here's another thing, because we're totally going out of the realm of optometry, right? Because it could be a vestibular issue causing that. There's a lot of times where we activate the vestibular system and it like totally fixes that. So you can do like some integration stuff and suddenly their convergence insufficient goes completely away. Or
Right.
their 20 diopter exophoria goes down to like 3 or something. So there's times where you don't necessarily need to do these exercises like strictly vision exercises to make that better. But I'm going to talk about it as if there is nothing else going on, if that makes
Mhm.
sense. Okay. So if they strictly had a convergence issue, which honestly in my practice I've never seen that. I've always seen a vestibular related thing in all the cases. But let's just say there wasn't, right?
Yeah.
Say we did the vestibular integration, they still have some issues still. So like in convergence insufficiency, we're trying to train the brain to be able to converge their eyes and focus their eyes at the same time at the same plane in space. So if I'm reading a book like this and the book's like 16 inches from my face, I have to turn my eyes at that same point and I have to focus that lens at the same point to see clear and comfortable. So I guess to break it down even more, what we're looking at in like vision therapy, in the vision therapy room, we're looking at clear, single, comfortable vision. So clear means, clear your vision. Single is obviously not seeing double. And then comfortable is having your eyes being comfortable. So we're kind of trying to break those down and hit those goals of those three categories. So when you're turning your eyes in on a book, you have to turn in on that spot and focus. So you can turn your eyes at the same spot, but it can be blurry. You can have it clear but be double. So if your eyes are focused on the book, but your eyes are pointed in front or behind it, the words won't necessarily be double. A lot of times people won't report double. This is another thing too. If your eyes aren't pointed at the same spot, say like you're looking at the book and the eyes pointed in front of it, so your eyes are over converged, a lot of people won't say they're seeing double. In most cases, they'll say like the words are moving when I'm reading the book. So it's not like a double, it's like more like this. So it's kind of like this shadowing. So it's just barely overlapping. This is what they're doing in real time. The words are going like this, just barely overlapping. So they say the words are getting thicker and thinner. They're moving, and then what happens in result to that moving and shifting? They might have their eyes glitch, or they might have a saccadic issue and so forth, where they're missing their spot on the page and they have to refixate to find the word again.
Let me ask you
That's
this.
kind of the breakdown.
We talk about convergence deficiency.
Yeah,
What
yeah.
other eye movements do you look for, and what type of symptoms do you see if some of these eye movements are dysfunctional?
Yeah, that's a loaded question. Because you're like when you're reading a book and you have convergence issues, right? Your eyes are turned into the same spot. So we're talking strictly about convergence focusing now, right?
No, we're
But when
talking about
you're
other things.
actually
We're talking about other
but
things.
when you're actually reading a book, you're not just doing this and
Mhm.
focusing. You're doing this, focusing, and you're doing pursuits and saccades all and gaze fixations throughout the whole thing, right? So if you had like an eye tracker on your eyes and you see someone read a book, they're not just doing this and going like that. They're like kind of going like this. And if they're perfect, they have the perfect eyes, it'd be strictly right spot and be boom, 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 boom like that, right?
Mhm.
And I actually had one person like that. There's this girl, man. Oh my gosh, she was like, when we talk about like reading, so like how everything was perfect. I'm like, wow, like literally no glitches anywhere. She's like, boom, 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 no concussions or anything, right? But she's one of those persons that could read a page and remember every single word on it. But that again, talking about her brain function
Yeah,
was like superior compared to our analysis.
for
But I
sure.
guess when talking about eye movements, like you're involving so many things. You're involving convergence, you're involving eye focusing, accommodation, you're involving fixations, pursuits, and saccades when you're reading a book. So when you have convergence and sufficiency, you have a breakdown in all of those categories.
And do you find that maybe reading is a good sensitive question to ask people because it's so complicated? And when people do have concussions or
Yeah.
they end up having reading problems, or what other problems do you see besides reading?
I just asked him like, yeah, like how are you doing with reading? Like, is it like harder to like, is it hard to read? Are you miss skipping lines? Are you having to reread lines? When you read a page, how is your comprehension? So that's what I do with reading.
Mhm.
With convergence issues too, like I ask them about because a lot of people are working, so I ask them about computer work. How is the computer work affected? Like, are you able to stay on the computer and be fine? Are you fatiguing? Do you have eye strain on the computer? But in pretty much anything that's up close, right, on your phone as well. And here's the funny thing too, like they may be like, well, when I'm on my phone, I'm okay, but when I'm on the computer, I'm not. And you think it'd be worse on the phone because it's closer, but it's kind of like a good example of that is like, well, if you're doing something you really like you're doom scrolling down like Facebook and stuff like that, you're gonna like power through that and not worry about how your eyes are feeling.
Mhm.
When you're at work and you have to comprehend, it might cause more visual strain there, and that's why it might be harder to do like the computer versus the phone.
Okay. And let's
Yeah,
let's break it down a little deeper. When I talk to
yeah,
people, I tell them you've got two things that let's talk about concussions, right? Because concussions are
hmm
classic, but we could relate this to dizziness. We can relate this to autism. And I know you've got some personal background and history on autism. You can relate to ADHD. You can relate to a lot of conditions. Our brain is an organ which takes in our environment and tries to predict it, right? It's a
yep,
predictive organ and it's
yep,
reliant on your past history, your
hmm
experiences, but it's really reliant also on the quality of information you get from your environment. So
hmm
obviously we're talking about vision. One system could be your eyes, right? Where your
hmm
eyeball is picking up information. It goes to the back of your eye and your retina. And then right off the bat, that optic nerve is kind of part of your brain, right? And so you kind of go right into the back of the brain. It goes into these reflexes areas in the bottom part of the brain and the brainstem. And then you
hmm
further integrate it more and more. And you've got this visual system that we say could have a visual error. It could have an
hmm
error because you've got glaucoma. It could be an
yep,
error because you've got inflammation on the optic nerve. It could be an error because somewhere in the back of your brain that takes in vision had a stroke, had a
hmm
concussion, but that one system can have an error that distorts the quality of input, right? And I would say
yep,
historically, that is probably where more optometrists lived, is
hmm
saying we are in the lane of vision. We're not in the lane of other conditions, vestibular, proprioceptive. That's your lane. we're going to stay where we're at and we're going to just make sure your static vision is good, right? I
Yeah,
think where the challenge becomes, like you're going to talk about in a minute, like you've discussed, is we have other systems that also go into our brain, sometimes independently, and sometimes it integrates with vision right away. So you can have
for
a
sure.
vestibular error from your inner ear, and it could be because you got hit in the head or you went diving and you blew something in your middle ear. It could be because you have inflammation on the vestibular nerve instead of the optic nerve, right? It can be, but when you look at the vestibular system, the second it goes to your brain, it's already communicating with other systems, right? You don't really have an area of your brain that's vestibular only. You could have a whiplash injury and you could have a neck injury that now is a sensory error from your neck that can give you neck pain, but it also can interact with other systems. You can have a
Mhm.
hearing problem, blah, 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 right? And so overall, we can look and say, let's evaluate each system one at a time. And in today's society, what does that mean for a patient? It means they're going to go to an optometrist, they're going to go to ENT, they might go to a physical therapist, they might go to an occupational therapist, maybe they're going to go to 4 or 5 different people. Each person is going to evaluate the error in that one system, and they're going to get therapies based on that one system, right? And I think that right now is the problem, although it's better than cocooning and keeping people in a dark room. I would say that's one of the challenges in concussions is we've segregated people, and instead of isolating them by themselves with no treatment, we've isolated the treatments from each other. And that brings us into a
100%.
sensory mismatch. And what a
Hmm.
sensory mismatch is when one system is saying something different than the other. I always tell patients like a game of telephone, your vision's saying apple, your inner ear saying apple, your neck is saying orange. And now
Yeah.
your brain is in a conundrum. Who's telling me the right story? And who do I have to shut up? Let alone if your neck
Hmm.
says orange, your inner ear says apple, and your vision says cucumber, right? And
Yeah.
then you're really confused. And so I think the future, which you're already ahead of the curve, is trying to understand these sensory mismatches and trying
Hmm.
to understand the cognitive load, how it relates to it, and trying to understand the predictive mechanism of how are we supposed to move and interact in our environment if the prediction is always different than the feedback we get from the environment, and how does that make people feel, right? And so what I'm going to
Yeah.
ask you now is because as you mentioned, you started really specific to vision. You had personal experience with it. You did vision therapy. You got some improvement. But now you're talking about vision. You're jumping right to the vestibular system, almost looking at the mismatch that you would see almost like with motion sickness, right?
Hmm.
And you look, and for people that don't know, motion sickness classically is you're going in a car, your speed signal in your inner ear says you're going 50 miles per hour, but your vision says 70. And you get
Hmm.
this mismatch of signals of speed into your brain that gives you nausea because that mismatch actually gives you physical symptoms, almost like you had a bad food, and then people think, well,
No,
no,
it's
it's my
true. Yeah.
fault, right? So I'm curious with your progression over what you do. Now you're obviously doing balance, you're looking at the inner ear vestibular. What has been the thing? What was like your aha moment? Wait a second, these things communicate. And how have you taken that forward in your practice? And what's been your experience talking to other professionals, whether it's an optometrist, whether it's a physical therapist, a chiropractor, whoever it may be, who still is very one signal only, like one channel only,
Hmm.
versus trying to explain them that while it's great to get one channel to the brain appropriate, what might be even better is when those channels all agree and say the same thing.
Right. That's a good question. I think the first thing is that a lot of practitioners are afraid to do what they don't know or know little of, if that makes sense. And that's the hard part, and that's why they create this whole lane thing. And in my opinion, like if you're this is my opinion, if you're doing vision, you should know vestibular proprioception. If you're doing manipulation, proprioception type stuff, you should know vestibular vision. And if you're a vestibular therapist, you should know the other two just as well. Because you have to, in my opinion, integrate sooner than later. Because a lot of times we do like these separate things and trying to integrate stuff in the end. A lot of doctors actually they think they're doing vestibular. I'll say in my profession, they'll say like, "Oh, I do vestibular," and I'm like, "Oh, cool. What are you doing?" "Oh, yeah, we have them stand on this bouncy ball," and that's their extent of vestibular by putting them on a ball, and that's it. So like, I guess it's hard because like when you don't understand it or you have less knowledge, it's hard to apply it, right? And when you say aha moment, I mean, I think I have aha moments like almost every week. Like I literally when I went to your thing, just was it like a month ago or whatever it was. I'm like, I had a few aha moments there too. I was like, oh wow, like I'm just like a sponge. When I see stuff, I'm like, oh wow, that's cool. How can I apply that? And I literally applied all your stuff the next day, and I started getting
Amazing.
better results. So like
Awesome.
my aha moment started, I think, from that gym when I was moving athletes around because I did weight training, I do weight training and all that stuff too. So when I see athletes making this progressions to like translational moves and so forth, I had a aha moment there. I had a aha moment when I was with like Jeremy and Russ and in Barcelona, and we're like just teaching each other our stuff and we're like learning from each other. And I'm like, oh wow, I didn't think about that. Like
Mm.
so I'm taking these bits and pieces and as you apply it to your own practice and you work with patients, you're like, this is really cool stuff. I had a aha moment too, because like so when you're talking about like senses coming in and orientation and so forth, it's like it's based off the OTA loop. I don't know if you heard of that. OTA loops, John is it John Boyd or whatever his name is from the Air Force.
Mm.
So the OTA loop is observation, orientation, decision, and action. So observation is the senses coming in. Orientation is based off your genetics, culture, trauma, past experience, and so forth. Then you got the decision making process and then action, and it's like a loop. So like I kind of apply that loop to my practice. I look at all the senses and see how they can affect each other. A good example was actually just the other day. We're at our friend's house, and the wife like literally like neck issues, right? Been dealing with neck issues for 2 years, been to all these different practitioners, got it hammered on, adjusted, and all that kind of stuff. And like, and she's like, yeah, it just gets tight right pretty much right after. And I'm like, oh, cool. I'm like, that kind of sucks, but it's like, so I started like looking at it and like doing a few tests with her. And I'm like, I think you have like something going on with your vision vestibular. And in her case, I just literally did some like VR cancellation with her. And like literally, she's like, oh my gosh, my neck hasn't felt this good over 2 years
It's
just
amazing,
with
right?
VR cancellation. Yeah.
Yeah.
So, I mean, like you can apply that stuff so easily to your practice. I think it's just good to kind of like find other people in other professions to learn from each other and teach each other. And really, we need to stop using the word stay in our lane. Like, what I mean? Like a lot of doctors say that, and there's specific ones too. Like, I'll never adjust someone. That's not license wise. I just can't do that, right? So there's specific things. Obviously, we're just it is what it is. But I would say like literally 80% of our professions overlap so much that we can do that 80%. There may be that 20% that we just don't touch. And that's where you obviously want to refer. But I think if we all learn this stuff, like you're a good example too. I mean, you did the same thing in your practice. You have all that integration where I'm still learning, in my opinion. I think you know way more than I do. So like way more in the integration stuff, and I'm still learning. Where it's cool to see the stuff that you guys are doing there, and the patients you're able to help based off how you're integrating.
Let me ask you this. So I have a
Yeah.
patient this week, and she was concussed multiple times,
Hmm.
athlete, and was really dizzy, was really off balance, and was very symptomatic.
Hmm.
She went to different practitioners and did basic vision therapy,
Hmm.
basic vision vestibular therapy, shaking the head,
Hmm.
looking at dots, etc. And then it got to the point where she was much more functional. But then what happened was she felt like she couldn't turn her head. She felt very disoriented and she felt like her body, she wasn't in her body correctly. And she, like, anytime she tried to move, she got nauseous. When we did our exam, all of her vision tests were normal. Her pursuits were normal. Her vision
Hmm.
acuity was normal. Her saccades were normal. Her optic kinetics were normal. We put her in darkness and everything looked good. The second we turned her head and caused a cervical distortion and just held
Hmm.
it there, she started getting nystagmus, right? And so I guess my question to you is from what we did, is our goal was saying what we're going to do is do therapies to communicate your neck to your inner ear and your brain,
Hmm.
right? Because when
Yeah.
we the vision on, everything looks good.
Hmm.
But when we lose your vision, you still look good until you turn your head. And the second the neck input is distorted, you get a vestibular response, which you shouldn't get, right? You can't really do
Hmm.
that volitionally for most people. And
Yeah.
so my question to you is that the vision therapy really helped, but it might have been more of a compensation, which maybe she needed at that time. But
Hmm.
eventually it maxed out how much function they can improve.
Correct.
right? And
And
so,
that's good. That's a good thing you brought up, though.
hmm,
Like, I actually like what you just said there, because when you have a mismatch, a lot of times when we test, let's bring up the cover. Let's bring up the Maddox rod cover test, right? So eye alignment.
yeah,
Most people test it in primary gaze, straightforward, and they test it with their eyes up here, here. So in the cardinal gaze, it's with your head still. Most doctors, eye doctors, do not test that with rotations or tilts or and so forth, right?
hmm,
So I actually do that in my practice. So if I see a difference in how their eyes are functioning or eyes are moving from like right rotation, left rotation, and depending on where it's actually happening, I may send it to a functional like neurologist or something like that, or whatever, one of you guys or whatever, right? If I don't feel comfortable doing it. So I guess my best advice, given what you're saying, to any doctor out there, if you're testing vision, don't just test it in primary gaze, test it with your head moving in different directions. And if you see something off about that, you know there's a cervical thing going on there. And if you don't feel comfortable treating that kind of stuff, then send it to someone that can, and that can tremendously help the vision therapy out. A good example, kind of backtracking now, there's a few patients I saw recently that done vision therapy for 2 years. So they're doing vision therapy for 2 years, and there's nothing wrong with that. I mean, it is what it is, right? I mean, I'm sure they got good results from it. But when they came in, I could still see a lot of dysfunction, and a lot of it was based off cervical, vestibular, and visual mismatches. And like literally, when you just kind of integrate it, like within 1 or 2 sessions, they feel like 30, 40% better. And so I guess my advice would be is if you see issues in those other areas, learn how to do it, learn how to apply it to your own practice, or send it to someone that can do that part first. Because there's a couple of guys where I literally just did that. So I actually had a referring eye doctor send me one. So I did the stuff, and then I did the stuff, for a few sessions. I sent him back to do the vision therapy. And I could have done the vision therapy, but since I was referred, I have them obviously do it because they're doing it. So
sure.
that's a good example that you brought up, where it's good to test in different head positions as well.
For sure. And I think what's
Yeah.
interesting is though, although this gets complicated, it's almost as simple as if you assess it and see the head left makes things worse,
Hmm.
you can literally do your vision therapy with their head to the left.
Yeah. That's how
Right?
easy it is. So, I mean,
It's that
and if
simple, but
that doesn't work, then
it's amazing how
if it
much it
doesn't work,
works,
then set
right?
it right. Yeah. Yeah. Yeah.
It's
Yeah.
like almost I tell people this is going to seem stupid, but you're going to feel a lot better quickly. And so bear with me, right? And then
Yeah.
really
Yeah.
quickly, we just do some therapies with their head turn and reintegrate that
Hmm.
distortion. And
Yep.
before you know it, it's a completely different therapy than with their head straight.
Oh, 100%. And then again, most doctors will do, so this is classical vision therapy, okay? You sit down, perfect ergonomics, like 90-degree angles, right?
Mhm.
Everything's 90 degrees. Your head's perfectly like that. You have the thing right here, and you have to stay still and do the vision therapy. I'm like, in real life, no one does that. You tell someone to sit up straight. I mean, how many times are everyone slouching? And I actually have pretty good posture, and I still slouch, right? I mean, like everyone's like they're laying on their bed studying. I'm like, you're really a kid's going to be studying on a freaking desk all day long. You know what I mean? No, they're going to be laying on the bed. They're going to be laying on the ground. So in real life, it is what it is. We're moving. We're always in locomotion. So that's why it's good to test those different directions and rehab it in those directions as well.
For sure. And
Yeah,
so
yeah.
let me ask you this, because I think when people, especially with concussions, but when I think people think about optometrist
Hmm.
or vision therapy or even diplopia or double vision, I think the first thing that comes in people's minds are prisms, right? And I
Hmm.
think there's been a historical reliance on prisms, and it's not good or bad, right? I think
Yeah,
it's a
yeah.
tool, right? And so I think there's been a reliance on this tool to really help people in different ways. And as you know, people use prisms differently, right? So it's
Hmm.
not just like one way to use a prism. There's different methods, there's different philosophies, there's different ideas of how you do prisms. And so I'm curious for you, your interpretation of when you first started learning, kind of vision therapy, kind of how prisms were taught, and kind of
Hmm.
your interpretation of how you could use prisms. And then as you practice more, how it's evolved into why do you use prisms? When do you use it? How often are you using it now compared to when you started?
Yeah, for sure. So like talk about general optometry versus like vision therapy doctors. I think vision therapy doctors understand prisms a lot. General optometry, they understand it, but the reason why I say they don't completely understand it is because anytime you put anything in front of your eyes, you can put like a plano, like a no power lens, this piece of plastic, and that piece of clear plastic, when you look through it, will change the speed of light of how the image is coming in. It still distorts it in a way and modifies it in a way where if you didn't have it on, it'd be a different image. So your brain's processing something differently. So when you talk about even plus lens and minus lens, plus lens magnifies things, minus lens minifies things, and so forth. So it changes the trajectory of the image going onto your retina and then going back into the back of your brain, and your brain has to interpret it differently. Same thing with prisms. So prisms can change the way the light is bent into your eye. So every lens is going to modify your interpretation. So just putting a lens in front of your eye is going to change your interpretation. So that we have to take that in consideration. What most docs think about non-vision therapy docs, they think Prism as like more compensatory. So like basically if your eyes in like ESO and they're seeing double, then they're gonna put a base out Prism to compensate for that, to make it so it can do the work for it so the eye doesn't have to work. Same thing with the exophoria, they do a base in Prism. So if you have an exophoria and it's basin that compensates, or if you're training, a lot of times you use base out to train the exophoria as well. So like we're using it as that sense, but in most cases, when you see prisms and glasses, that's more compensation to do the work for them. And what happens is even a prism itself or a plus and minus lens, that could effectively change your view or gain. It could change your vestibular input because the eyes communicate with the vestibular system. So that's what we have to always take in consideration, that that might modify those pathways. But a lot of times we're only thinking, okay, eyes in, I got to put a base out prism in. Eyes out, I got to put a base in prism in. And that's mostly what you're thinking about when you're prescribing it versus actually like seeing how it can modify the other systems. So like a lot of times too in vision therapy, now we're talking about the vision therapy world, a lot of times they'll put micro prisms in, like maybe put like a half basin prism, which means like, the basin on both eyes to kind of relax the eyes when they're trying to converge. So like that's where you see a lot of prisms like that, or a lot of times it's vertical deviations. They'll put the base of base down prisms as well, to compensate for that. A lot of times what happens is the brain kind of adapts to it. And then every year, so what I see in my practice, I have a patient come in and like they said, like, every year they show me all the prescriptions. It was like a half basin up, then it's a one base up, then two base up and down, kind of and so forth. So every few years it gets worse and worse and worse because the brain's adapting to it, and it's so you're not calibrating the brain, you're doing compensation, so the brain can't calibrate because of that. So like a lot of times, what I see in my practice when I see that, we'll try to see if we can do like where initially I just did vision therapy and now I try to do integration right away. And a lot of cases where I see in my patients where they have a vertical deviation and they're like in two base up and down prisms, I'll do like some visual vestibular integration exercises with them, like actually in the exam to see if it works. And then I retest, and like a lot of times that like if they had like a total of an 8 vertical deviation, it goes from 8 to like 2 or 1, which was with one move. And when I see that, I'm like, okay, that's completely an integration issue. So like just off that, a lot of times I get the person out of prism right away. Like literally, I just had one the other day. This lady that had a concussion was doing vision therapy for like 2 years. Heard about my practice, came in. She had a two up and down vertical deviation, and we just did some calibration stuff. And literally, she wasn't seeing double off that. Double went completely away, and there was no need of prisms anymore. Then we had obviously had to fine tune it over a few sessions, but we got some really good results with that. So
Amazing.
prisms, I used to initially, I probably I was probably one of the few where I really didn't prescribe prisms much, but I still prescribed them more than I probably should have. And now I kind of do a wait and see approach. The only time I really prescribe prisms is if they really need it, like they're seeing double and they can't function. I'll prescribe it there as a temporary thing to kind of get them so they don't see double. Because if you're seeing double, they can't drive a car, right? They can get in an accident. So that's where I probably would prescribe it just as a temporary thing until we can calibrate the brain better. so they don't need it anymore.
For sure.
Um, but a lot of times I'll use a binasal too. If they're seeing double, I'll use like a binasal or some kind of like sectorial occlusion, just to occlude part of their vision a little bit. And if we get rid of the double there, then we don't need to put prisms in, and we can do the therapy while they're using that as well.
Amazing. So let's jump ship a
Yeah,
little bit because we're talking a lot
yeah,
about people with problems, all right, with like
yeah, yeah, yeah,
concussions or
yeah, yeah.
diplopia. Your background's in athletics. So let's talk about like a major league baseball player, right? Because you look at vision therapy, I think it affects everyone, including water polo,
Hmm.
right?
Yep.
But I think maybe baseball, because the game is so fast and it's about seeing
Yeah,
ball, is
yeah.
maybe they're a little more open and in tune to trying vision therapy because it seems to like make more sense versus other sports that maybe, you might have not, it's not a one-to-one correlation as much. So let's say you've got a major league baseball player coming in and he says, "Look, Dr. Brewer, I'm just trying to be better at baseball, right? I'm
Hmm.
trying to improve my hitting, my fielding. I want to improve my contract. What can you do to make me better? They're not concussed. They don't see double. What kind of assessment are you doing, and what are you like looking for in order for like optimization of a player?"
That's a good question. Yeah, so the basic assessment is pretty similar still. It's just that they're going to be above normal. So a lot of times, 'cause I work with some major league players and so
Mhm.
forth, and um, but basically, I actually work with a couple of docs where we actually work with the Blue Jays as well, which is kind
Oh,
of cool.
wow.
They're in the World Series right now, right?
Pretty
So yeah,
cool.
so like that's pretty cool. The other doc has a main contract, but we help with them as well. But it's pretty cool setup. So like when we're there doing the training and so forth, like a lot of times when we're in we're going to talk about team setting and individual setting. Team setting, it tends to be a little bit more restrictive. So you can't do a lot of this integration stuff we're talking about, right?
Mhm.
It's like strictly we're here as eye docs. We're seeing clarity of vision. We're testing the contrast. We test eye alignment, all that stuff. But we're strictly just telling them specifically on vision. So even if I'm seeing this like visual vestibular stuff, we try to actually quote unquote stay in our lane there because that's all they want. They don't want any more
It's as if they don't
because
bat with their head turned,
yeah, yeah.
right?
So that's the hard part, but and then we have to stay there because it is what it is, right? And that's the
Mhm.
hard part. So now we're talking about the individual coming in separately, right? So if the individual comes in separately, I can do whatever I want now because I have no contract with the team. The person's coming to see me specifically. For like actual vision training, like a lot of times I'm just looking at anything that can improve their reaction time. That's the most important thing. Reaction time, even eye hand coordination, all that stuff is going to increase reaction time. So I use a Spider-Man analogy. Like if you can be like Peter Parker and see things go in slow motion, then that's really the best thing to do. And a lot of people, when I train them, they afterwards are like, I feel like Spider-Man. Like, so when you're talking about like a baseball swing, right? If someone pitches the ball, I'm just going to use a round number, a half a second.
Mhm.
It's about 0.4 seconds or whatever. But when the pitcher's throwing the ball in Major League, it's about half a second. So that batter has a half a second from that release point when they release the ball to when it hits the catcher's mitt at the home plate to make a decision on whether to swing or not swing to be able to read the ball, possibly see the seam on the ball, see if it's going to be a curve ball, if it's going to be inside strike, outside strike, if it's going to be a ball, like to decide where it's going to be at and then place their bat where they think that ball is going to be at. That's all when you talk about earlier when you brought up prediction, right?
Yeah.
It's all about predictive states. So like reaction time is based off prediction. So it's not just vision, it's includes all the other senses as well. But the first component with baseball specifically is if they don't see clear, then it's going to be hard for that reaction time to be faster. So the first thing we look at is making sure they have the clearest vision possible. So maybe like when they're playing baseball, we're going to correct them down to 20/10 vision, but maybe in regular life, they're going to have 20/20 vision with another prescription. So some athletes will have specific like contacts or glasses specifically just for the game to be clearer, but like, or for practice and stuff like that. And sometimes they'll wear it all the time. So we look at clarity of vision. We look at how we can improve their contrast. Because if they have poor contrast, then it's going to be harder to see the seam on the ball. It's going to be harder to differentiate the ball in space. So if they have poor contrast on the test, we're seeing how we can improve that. Then we look at the eye focusing too, because if their eye takes a long time to focus, when they're looking at the pitcher and they have to turn their head all the way down here to the bat, it's going to take a while for them to focus, and that makes things blurry, which is going to reduce the reaction time. Same thing with gaze. Gaze stability is actually really important. So a lot of times, if they have like even if they have good gaze stability, can we improve it even more? Because they have better gaze stability, they're going to be able to move their heads and keep their eyes in the same spot. And that's when you start looking at the vestibular function too, right?
Mhm.
Because when you're actually looking there and looking down here, that's a movement of the head, which activates the vestibular. You got cervical things going on there too, body movement, eye-hand coordination, and so forth.
And so, like, I
So
guess my question to you,
yeah.
and is you work with these high level athletes that we all do.
Mhm.
You
Yeah.
work with teams, which we all do.
Hmm.
And I think the average person is thinking you work with a Major League Baseball team. They want you to do the best thing that you can do to get their players as functional as possible. Why do you think that it's really not like that? As in a lot, not every team, but a lot of teams, it does
Yeah.
seem like they put you in a box and everyone's got their own box that they sit in the organization. And while there's good
Yeah.
communication and teamwork, I guess my interpretation, like I think baseball does a really good job because I think the metrics and the data they get is incredible. It's almost like they have too much data and they're
Yeah.
having trouble understanding what to do with it.
Yeah.
And they segregate things so everyone's looking at the data independently. And they might have a medical doctor that runs the whole thing, but he might not really understand or she might not understand anything you're talking about. So
Right.
so if, as a specialist that comes in, where's the communication at in your opinion? And like where do you it's better than it's ever been, but like where do you think the path forward is to get people to understand, like you said, hey, these baseball guys move their head fast to look at the ball,
Hmm.
right? These baseball guys have their neck rotated in balance.
Yeah.
I mean, I've seen multiple baseball players who got hit in the head with a baseball, ended up with a convergence insufficiency
Yeah.
was never picked up by anyone. And before you knew it, the teams were PRing them negatively and traded them, thinking they weren't hurt, and they were. And you fix the
Yeah.
convergence, and they're back, right? And so, like, I
It's
guess where's the
hard. Yeah.
disconnect between like functional improvement and top-down regulation of what you can do with these guys to get them functional?
Yeah, that's a hard one because obviously if you're working with an individual, you can kind of do whatever you want, right? But when you're talking about like teams, there's even like club teams and high school teams, college teams, whatever, there's a lot more politics involved in that. And that's the hard part. Like, because I feel like someone like you're like 10, 15, 20 years in the future of research, right? What you're doing now is going to be the standard 20 years from now. But we're not 20 years in the future yet. So that's the hard part. Like a good example, like, John Leddy, he developed the Buffalo concussion protocol.
Got that
So I
out.
actually just spoke with him at a conference in January and stuff like
Yeah.
that. And like literally like his method, when you talk about the actual Buffalo concussion protocol, if you rewind the time when it first started, people are like, that's stupid. Like, why would you do that? Right. Like, I mean, like other doctors, right? And
Yeah.
now everyone's following it. Now everyone's like, okay, that's kind of the standard, right? Because there's a lot of research on it now.
Mhm.
So I think as we do our stuff, like do this integration stuff, we'll get more research on it, hopefully. And the hard part with integration, it's really hard. You can do like research on clarity of vision, but it's harder to do research on like how does like on eye teaming and focusing because they're two separate things, but they work together. It's hard to isolate research on that. And that's the hardest part, I think, too, because like a lot of people are going off what is the gold standard on research. And how we practice, we use all the research that's available. We see the research, we use it as a baseline, and we're the ones pioneering and developing stuff in the future. We're developing the stuff that we research later on. So I guess the key as a practitioner is not just looking at research and following the research, but reading the research, understanding it, but using that as a baseline to develop your protocols.
I
And
love
that's
it.
where you become a true trailblazer. So I kind of look at doctors like, are you going to be a tech that just follows the research, or are you going to be a practitioner that uses the research to treat patients
I
and
love it.
develop your own protocols? Yeah.
And to your
And that's
point,
the hard part with all that stuff, right? Yeah.
I would say 15 years ago,
Yeah.
the
Yeah.
same type of doctors and sometimes the same people who were yelling at us because we weren't cocooning people as much.
Hmm.
And they were telling us we were hurting people and what we were
Yeah.
doing concussions was negative. These same people are now doing exactly the same technology we had at the time. They're doing
Yeah.
similar therapies because now the research has caught up, and all of a
Yeah.
sudden it's now the cocooning was negative, right? So all of a
Yeah.
sudden, so it completely went 180. And I agree with you. As people you're a classic example, right? Your background is more optometry, but you're aware of your patients, and all of a sudden you do something to the vestibular system, like, what is that? Right? Because
Hmm.
you have such a strong background, you said that shouldn't have changed that way. What just happened? Right? And you
Yeah.
start realizing, like you said, the integration between these multi-sensory systems and how the brain works, especially after concussion. But even with concussion performance, what other conditions do you typically see in your practice?
Oh yeah. So like a lot of, I'll say about 90% of my patients are concussions,
Okay.
TBIs. Typically in a vision therapy practice, it's usually about 10-20% concussions, 80% other stuff. But I do sports vision, I do athletic performance, I see like strabismus, eye turns, more like developmental stuff, right? I have special needs, people coming in like autism, ADHD, and so forth. So I see that. I see just general eye stuff. The hard part when you say like people are coming in for a convergence issue, a lot of times, my opinion is like, yeah, they have the genetics that makes them predisposed to that condition, but they could have had a viral infection that affected the cerebellum. It could have been a concussion affecting the cerebellum, whatever, right?
Sure.
Like, so they have this stuff that made their predisposition to this eye issue come be manifest. And so we're treating him as like, oh, I'm saying I'm treating a strabismus or an esotropia. Even esotropia, as you look at that, like literally their eyes are in, right? Well, there's a huge vestibular issue with that too. So we need to treat even the strabismus with integration as well. So they kind of like, I guess if I like look at it, like almost everything's like brain related, and if that makes sense, it's all brain related. Like, what caused the brain to make that happen, basically?
And that's interesting is I think
Yeah.
people, like to your point, and I get your input on this, is that a lot of people are so specialized in healthcare. I only treat autism. I only
Hmm.
treat concussions. I only treat this. And you're talking about multiple conditions, but my assumption is you probably assess and treat not so different, right? Because you're treating the
Yeah.
brain. And so talk
Right.
about it, like talk about how your progression is and like while people might perceive, how can you do therapy with someone, a kid who has autism and compare that to a Major League Baseball player? So why don't you kind of compare it and show like why
Yeah.
the brain is the brain, right?
Yeah. The brain is the brain. I mean, really, because you're looking at like a good example. I had a major league player. He was like a pitcher in the major leagues, and like he comes in, and like his trainer, like, you guys see this guy, right? So he sees me and do all the assessments. And he was literally 99th percentile for pretty much everything except for like three areas. I can't remember what areas there were anymore. I see so many patients, but like there's like three areas where he was like 50th percentile. And he's like, oh, that's wrong. Like he was like, totally, no, let me take the test again. I'm like, okay, fine. Still 50th percentile. He went 55 and 45, whatever, right? Pretty close to the same thing. And he's like, well, I don't understand that's going to help me. It's not going to help me. And then I'm like, and actually explained how it would. And then he like switching his head, like, oh my gosh. And he was like game on the whole time. And like he literally, because he was game on, it didn't even take that long. We just fixed it. Like it was so fast. And that's the cool thing with the professional athletes. It can go quicker because a lot of them have that mentality. If they understand why it's going to help, they're going to do it with perfection. And you
Cool.
just get really good results fast. And but the thing is, they're still treating the brain. They're looking at what parts of the brains are deficient, what pathways are deficient, and how do we normalize those pathways? Then how do we optimize those pathways? So I always look at normalization, optimization. It's all one continuum, right? So that relates to like special needs and other conditions where you test the brain and they might have a lot more deficits. So you're trying to see how to activate the brain to normalize those deficits and then optimize them. And even in autism, they'll have ones where they're like literally out here. Some autistic kids come in where like you're doing like a visual perceptual test and they're scoring 99 percentile on all of them, but then they have all these other issues, right? So like it kind of just depends on the person. So we look at it as brain. How do we test the brain? When we're testing clarity of vision, you're testing the brain. When you're testing eye tracking, you're testing the brain because every part of the brain deals with tracking, right? Everything from the frontal to the parietal lobe to, the cerebellum and so forth, it deals with eye tracking. So you're testing all parts of the brain no matter what test you're doing. The biggest thing is understanding what parts of the brains are being activated on each test. So I guess a good thing would be kind of, you have a course where like, when we do this test, this is what's happening, right? This is how you test it, and this is how you train it.
Amazing. And so let's
Yeah.
finish up a little different, okay? Because it's been great.
Yeah.
Favorite book or favorite movie?
Ooh, favorite movie. Man, I watch too many movies.
So
I'm
don't-
like I actually like, I'm kind of a dork. I kind of like the Marvel movies.
okay, nice.
Yeah. So I don't necessarily have a favorite Marvel movie. I like all of them, and I actually like the DC movies too, like Superman, all that stuff. I'm kind of a goofball like that. Um, I like, I guess one part of Thor, I always bring this one up to patients because people always say like what I'm doing is magic. They're like, man, it's magic. And I'll like, I'm really loose with patients. I'm like, yeah, let's do my voodoo magic on you. I don't even care. Cause like, and I'm just thinking a laxatives away. They all laugh because no, in the end, no one cares. They just want to be fixed. Right. But I tell them the quote, I'll even show them a video of the movie Thor where he's talking to Jane and talking about the Bifrost or whatever, and they're like, Thor's telling Jane, like, well, what your ancestors call magic and you call science, I come from a place where they're one. And we're kind of like that. We're combining magic, quote unquote magic and science and merging them into one place where people still think it's magic, but we can explain the magic with neurology and tell them why the magic is actually science.
I love
That's
it.
why I kind of like that movie. And Thor's just freaking awesome, dude. He's like super strong, right?
I
And
love
the
it.
favorite book, oh man, that's a hard one. I have too many favorite books. Yeah, I don't know. I have to get back to you on that one.
No
Yeah, I
problem.
don't know. I'm trying to think what kind of book I like.
What kind of books do you read?
Right now, I'm reading all neurology books. That's the problem. Like neurology of eye movement, specific rehabilitation. That's the, like, I'm
Nice.
not really reading like the general books like you read when you were a kid.
Yeah.
Um, I actually, when I was a kid, I liked comic books.
Okay.
So I was big into comic books when I was younger. Yeah. So like, but right now I'm reading so much like just neurology books. I'm like, it's more like I would say like neurology of eye movements is probably my favorite book right now.
Yeah, it's a good one, right?
Yeah, yeah, yeah. But like I talk about like fictional or non-fictional, yeah, I don't know. Like I'm trying to think what my favorite book was.
That
Yeah, I
says
don't
a
know.
lot about us that both of
Yeah,
us love Neurology Vibe Movements by Lee and Z.
yeah, because I mean, because all I'm reading now, all I read is that kind of stuff right now.
For
I
sure.
like actually, what? Take it back. I like the book, How to Influence Friends. Is it what's his name? My gosh, I'm brain farting the name of the guy. How to Win Friends and Influence People.
Okay. Okay.
That's
What'd
who
you
wrote
take
that
out of that
book?
book?
For that book, like really what it comes down to is like when you're trying to win friends and influence people, a lot of people like have this like fake face, right? Like in reality, you got to be authentic if you really want to make friends. If you're not authentic, you can make associates, you can make acquaintances, but you're never going to truly get to the point where you're gaining friends.
Interesting.
And influence is not, there's a difference between influence and manipulation.
Mhm.
Some people manipulate people, strong leaders will influence people.
It's a
So
subtlety,
that's the
right?
biggest thing. But
It's
you
a,
can only influence people if you're authentic self and you're really genuinely trying to help people.
for sure.
Yeah.
Let me ask you this. If you were not in healthcare and you weren't a doctor, what would you be doing right now?
Surfing.
I love it.
I didn't even think about that one, right?
That's a
I'd
quick
literally be
one.
in Hawaii and just surfing on the ocean.
Amazing.
If I had a choice to do something, I'd just surf every day. Like surf and
Amazing.
fish. Yeah.
Cool. And then last question. If you had to have dinner with anyone dead or alive, who do you want to have dinner with and what do you want to talk about?
Wow. That's a good one. Like probably the first person that ever lived.
Okay.
And I guess if you're talking about like more religion, you could say Adam, right? Because he's
Yeah.
technically the first person that ever lived, I mean, whatever you want to call it, but
Yeah.
the very first person that ever lived.
Okay. And
So
so,
I would have to say, and then from with my beliefs, I'd say Adam, right? I mean,
okay.
who
And so
knows?
you
It might have
guys
been
might,
someone else, right?
who knows?
Yeah,
Maybe you're having a conversation. Maybe you guys are singing to each other. Maybe you guys are grunting to each other.
yeah. To see how it was way back then.
I like it. That's
Yeah,
amazing. Well, I really appreciate your time. I really
yeah.
appreciate your expertise, and I really appreciate you taking the time to educate people more on vision therapy, on the brain, and on
Thank
the
you.
future of rehab, right? And the future of brain stimulation. Because while everyone now is really jumping on more neuromodulation, TMS, direct current, PMF, laser, light, all those things are amazing. Inherently, they're non-functional. And while they
Yeah.
can do really positive things to the brain, there's nothing like functional activity that involves sensory motor integration and prediction. And even you look at the research with all this neuromodulation, it says it's not that it's insignificant, but it's a magnitude better when you incorporate it either before or during a functional activity. And so,
Yep.
regardless of the movement right now, it's easier to protocol TMS. It's easier to protocol these things, but we're always in a need. If you can't read, you can do some TMS, but if you have a convergence insufficiency, you probably are better off fixing that. And maybe
Hmm.
combining the two could be quicker. And maybe it could
Yeah,
hold
actually.
longer. But at the end of the day, without the functional activity that you're talking about, you're limited in how well you can improve function, whether it's someone on the spectrum, whether it's
Hmm.
someone after a concussion, or whether it's a professional athlete, right? All these methods are good, but understanding physiology,
Hmm.
understanding movement, understanding how the brain works, it opens the door for like an exponential improvement in your care.
Yeah, for sure. And
Awesome.
actually, I will do photobiomodulation with convergence exercises,
Amazing.
which yeah, so I just merge them together basically.
Amazing, man. I always
It's
appreciate
awesome
your
stuff.
time.
Yeah, thank
Amazing.
you. Appreciate
Thank
it.
you so much, man.
Yeah, thank you, man.